Good afternoon, everyone. I'm Dr. Hobe from Salini Hospital. I'm sure a lot of you have met me before. Please excuse my voice. I tried getting out of chairing a session, but when you're in the organizing committee, you just have to. But this afternoon, I actually have a great pleasure of introducing two of my favorite people on earth. So Dr. Adam Ashka and Dr. Cyril Nkabinde, who have both worked in Bethesda Hospital, northern part of KwaZulu-Natal. We worked together for some years actually. So on asking them how they would like me to introduce them, they basically said, just say the basic. They're all being so modest. But I think without wasting any of their time, let's probably just get on with it.
Thank you, Lungi. So, as Lungi said, I'm Adam Askar, and standing next to me is Cyril Nkabinde. We are in a relationship of sorts. He's my MMed supervisor. I'm a family medicine registrar now, but we're also working together on this project as a separate thing, and he's going to be here to answer the difficult questions that you pitch to me that I can't answer. So basically, we're going to be talking about rural proofing the primary care literature in South Africa. The way this came about was that earlier this year, the South African Family Practice Journal reorientated its editorial board, and I don't quite remember how it happened. I put my name forward or something like that. I'm the Rudasa representative on that board, and I was given this job description of ensuring that the rural primary care coalface is represented and helping to ensure that the CPD section is relevant to rural primary care doctors. And I didn't really know how best to do that. I have my own ideas, but what works for me doesn't necessarily work for everyone. So what we've set out to do is try and define the professional and academic development needs of rural healthcare practitioners, and as a secondary objective, identify how this specific journal can aid in addressing these. In order to do so, we did two things. We did a literature review, looking at the past 10 years literature around how rural doctors and rural healthcare professionals address their learning needs. And then we also looked at the Rudasa Forum over a 5-year period. Essentially, I think in my inbox I found almost 5,000 emails from Rudasa over that period, and then it was a very subjective process. I screened the emails, saw if they were relevant to learning and education, and then kind of read them in detail and worked out what themes emerged from those. In terms of the literature review, there's not much to say. Essentially, in high-income countries, rural training programs are quite well described and well researched, but there's not much from our setting. There is a recent published literature review that concludes, one of the conclusions is that doctors practicing in rural communities have unique educational needs, and I'm sure you know that already. You don't need a paper to tell you that. There are some older articles, some anecdotal. I found something by Prof. Ian Cooper where he made suggestions on how to improve the learning environment in a rural setting, and there are other evidence-based articles, but they're older. There's very little from South Africa per se, but Cyril is currently doing a PhD. Excuse me. The title is "How Do Medical Doctors Working in Rural District Hospitals Understand Their Learning and Their Learning Needs?" So that's quite exciting that we're actually going to have some data that informs how rural healthcare workers can optimize their own learning, how they perceive their learning, and then try and use that as a springboard to create something reproducible and sustainable that can be rolled out at multiple facilities, basically. That's the vision, as I understand it. Moving on to the review of the forum. So there were two main themes. What can you do as an individual, and what does your facility do to help with your learning? As an individual, you need to be an active learner, identify your learning needs, go and do something about them, review, keep going on through the cycle of learning. But there's also this concept of being a passive, receptive learner, and that just speaks to being open to the fact that around the corner there might be another learning opportunity. There's also a concept of inspiration. So this conference is inspirational. There's a lot of online buzz and excitement in the few weeks and months before the conference. And I hope that and the actual inspiration that you get here, you're able to take back to your facilities, give feedback, and inspire other people. That's definitely a theme that came out from the forum. Moving on, your facility, your organization, so this concept of organizational culture, how does that support you as a learner? Does your manager promote learning in your facility? So is there a CME program? You can see here on the 1st of April 2016, I was supposed to talk about drug-induced liver injury. I didn't really know much about it before then, and now I'd like to think I do, partially because of this talk, partially because of working as well. So is there a CME program in your institution? Are there M&M meetings that involve you as the coalface worker, or is it just happening in a boardroom with management? Are there grand rounds? Does your manager give you responsibility? Do they say you're going to be running TB ward for the next 4 months, good luck? Or do they say you're going to be running TB ward for the next 4 months? I'd like you to think about how we can improve quality. I'd like you to implement the new, or help with implementing the new MDR-TB guideline, that kind of thing. So there's a difference in how your manager manages you that can promote or dissuade learning. Does your manager give you time to attend courses? Was it easy for you guys to come here? Did you have to fight and motivate, or did you just have to say, I want to come to the Rural Health Conference, and the response you got was great? Does your manager arrange on-site learning opportunities like an ultrasound workshop at a weekend, for example? And it's not just about your facility management. Is your district management into promoting learning? Is your DCST pushing ESMO? And is that rolling onto you to kind of keep you upskilled in the obstetric domain? Two other things: engagement with specialist services. So is there an in-reach, outreach service that supports your learning? Is your institution hosting medical students, whether from overseas or local medical students? Because remember, teach what you need to learn, that whole concept. In terms of other resources, one of the Rudasa members came up with this concept of the updated Maslow's hierarchy of needs. So in order to learn, you obviously need food, water, warmth, rest, and good mobile internet, cell phone battery. And it's not just about learning and going on to up-to-date and EM guidance, but it's also having access to things like Vula that help you with learning. On the subject of online materials, that needs careful curatorship. Everything does, actually. You need to reinterpret everything in light of your rural environment. So you're reading a book, is it relevant to me? You're on a website, you're on UpToDate, is it relevant to me? You go to a course, is this CPD about the organization of care, or is it relevant to me as an individual? Thankfully, Rudasa and other organizations like University of Pretoria, Department of Family Medicine have done some curatorship around that. They've got good resources on their websites that are specific for the rural environment. Thank you for our star guest joining us. On a wider scale, you can think, or a broader scale, you can think about postgrad diplomas and degrees. They often come up as a often debated topic on the Rudasa Forum. And then something that's emerging is this idea of mentorship networks. So you have to stay in this room after my talk to find out more about that. I may have given the wrong name, Rural Champions, but maybe you can stay in the room and give it a name, this whole idea of mentorship networks specific to the rural environment. Some challenges that came up, so human resources for health. If you're one of 2 doctors in a hospital, how are you going to find time to learn? Task shifting. If you're one of those 2 doctors and then the system means that you also need to pick up the phone and book ultrasounds for your patients rather than being able to give that to someone else that's got common sense, that's also going to inhibit your ability to learn. Travel time. It was easy for me to get here today, 2-hour drive or so, but I'm sure some of you drove for 4 hours to an airport, got on a plane, got out of the airport, drove a lot longer, and I'm sure you've got some stories about how you came here. And that's relevant in the rural setting. Addressing the skills gap in low volume settings. If you're a practitioner in a place that does a handful of deliveries each month, how are you supposed to stay up to date with your O&G? And sustainability and reliability of specialist support. So there might be an outreach program, but what if it's reliant on the specialist coming in a plane and the weather's bad and then the specialist can't come and you have all these patients waiting? You don't really know what to do with them. Or the specialist who's interested in outreach quits, and then the department no longer is interested in providing outreach. So moving forward, how can the journal help address the gap? Well, just because it's a journal doesn't mean you need to be publishing original groundbreaking research. You can write a letter to the editor in a response to a publication in a previous edition, or you can write an opinion piece, which is basically a discussion around a topical issue. Just flicking through the last calendar year through the journal, there were only 4 articles that are relevant or specific to the rural context. So I guess I need to work harder on creating a platform for rural health to express itself in the South African Family Practice Journal. So in conclusion, I hope that you can see that learning depends on your learning needs and styles, which you need to go away and identify, but also the resources available. It's interesting that none of the Rudasa chatter really picked up journals. Is that because people take it for granted and they get their copy of the SAMJ, they flick through it and they learn on and off? Or is it because people don't consider journals to be useful in learning? I don't know. I guess I need you guys to tell me. In terms of taking things forward, so I'd invite you to engage or collaborate with us. Please, well, I'm going to open up the floor shortly. If you don't get a chance to speak, email me, send me a tweet, tweet the journal. Also engage with Cyril, although he's got ethical approval for the project running in Umkanyakure district. If you're interested in reproducing what he's doing in your district or province or your setting, then talk to him. Watch out for other relevant research. So make your needs known through research. There's going to be something circulated soon on the Rudasa forum about the utility of medical apps in learning. So let's make sure that the rural voice is heard in response to that research question. Attend the workshop that follows this talk. If you're really interested in medical education, go online, go on the WONCA website and get this guidebook about implementing medical education in a rural setting. And then look out for us hopefully next year when we hope to run a workshop around this subject where we can afford a bit more discussion. So thank you, and over to you.
Awesome. Thank you, Dr. Asker. So just in summary, I think Adam has managed to actually get all of us to start asking ourselves, what are our learning needs and how are we addressing those learning needs, especially based in rural communities. And traveling time, you have to travel from Mossford to Durban just for some training. Would you rather not just look at your computer and fill in some CPD points, questionnaires? So yes, let us now welcome your points, your discussions, questions.
So I'm just sharing my experience. I've worked in different rural district hospitals. And I find one of the main things that drives education is actually the leadership, like medical manager, clinical managers. If they're intent and keen and focused on continuing education, then it filters into the rest of the team. if you have guys that's not focused on that at the top, it's quite difficult to get the whole team to be motivated, and you also become sluggish with regards to it. So I think the leadership in terms of the medical manager is quite important to set the tone.
Afternoon, I'm Harvey Williams. I'm the family physician for Mkanya Kude. So part of my job is to really try and create networks. So I would, support the idea of learning networks, and I think learning networks also need to include your local regional specialist hospital, because your needs do depend a bit on what they want. For instance, if they say, look, we want you to be doing your below knee amputations at your place, then that's fine, then you learn how to do it. It's difficult if they say we don't want you to really do your appendixes, then you probably won't learn. But you tend to have to learn with their blessing. What you do at your hospital has to involve them, so that you're all happy with what you are doing in your hospital. That's one comment. So it needs to include it's not just rural networks, you need to include also your referral networks. You all need to be sort of talking to each other. Thank you.
Thank you, Harvey. Next up, I hope those that are from outside Mkanyagute are getting ready to say something. And ex-Mkanyagute.
Hi everyone, so my name is Jane Bezuidenhout and I live in Maritzburg now, but I worked in Msoleni for quite a few years. I think one of the major issues with the continuing professional development in rural areas is the government's human resource development policies, or lack thereof. I think, sometimes there will come up a course and they, must send people. And so you'll find actually it may be a course that's not necessarily what you would want to have learned, but you have to send someone, so someone gets sent. But core skills like resuscitating children or advanced trauma life support are not courses that are actually done or supported by the government, but they're actually key to working in a rural hospital. So I think I definitely think there could be better engagement from the human resource development in the government setting to actually look at what doctors need really to learn in a rural hospital, and to fund that. Because the costs, I found the 1 year I basically spent possibly my rural allowance going to conferences and courses. So that's my comment.
So you don't think that the
Thank you,
learning
Jane.
needs identified by head office are necessarily relevant to the rural setting? Okay.
So maybe just before Jenny speaks, but just to add on what you're saying, so it's interesting that literature also says that a lot, that many a times these great CPD programs that individuals will organize and force people to go to don't actually speak into some of the things that we might need in a rural environment, and in that particular context. And so I think really the engagement now with what the journal is also trying to do is saying, so what are our needs, and how can our voice be heard, and how can we get the resources that are relevant for us. And so that's why we're sort of encouraging a whole lot of more talk coming from physicians working in the rural environment to say, well, you guys are seeing a lot, you can publish a lot that will help another rural hospital, in that particular setting. And I think the whole research that even I'm engaged with through this process also is not just saying what are your learning needs, because I think we've asked that question a number of times, but rather getting to the how do you understand your learning needs, and what you need to learn in that environment, and then how can we elevate that and actually start to have conversations, and then possibly even some expertise coming from the rural environment on what we can develop to assist that. So I totally agree with what you're saying, certainly.
The voice of the professionals.
Hi everyone, my name's Jenny Nash. I'm originally from Mkanyagute. I just want to reiterate what I was going to say is often the sort of development is seen coming from the top down. So you'll be told that there is a course, and it's usually at fairly short notice, so you have to rearrange rosters, and it causes a little bit of chaos as to who's going to go and how you're going to get there. And if you're lucky, it's not cancelled sort of at the last moment. But the problem is that sometimes that doesn't totally speak to what the hospital actually needs. And so, if, for example, in the country, there's lots of variations in our own, even in our own provinces. So, when I worked at Mkanyagudi, you need to know how to treat malaria and the complications. I've seen one malaria case in 11 years since being in the Eastern Cape. But if someone gives money to to National and says we need to train everyone in malaria, it's very inappropriate to teach, Eastern Cape people about malaria. We actually need to learn about something else. And so perhaps that's the role that this can play, is to gather the voice from even more localized, districts and provinces, and to say, as you're saying, this particular area, we really need to know more about this. But in this area, we actually really well covered, because you start to see that the same people get recycled into some courses, and you have ESMO-E again and again, and actually we don't need ESMO, we need something else. And so perhaps that's the role in more coordinating some of the courses, and also from our last speaker to be able to have the guts to stand up and say, actually no, we don't want to do this. And that's perhaps where we need to start engaging at a high level, to say we're resisting, not resisting in a bad sense, but we're putting forward another alternative.
So I'm from Zitulele. We, in the last couple of years, have started this decentralized family medicine program, which I think similar is running in KZN, has been going for a while. And one of the things that it's done for us is it's helped us develop relationships with our referral center. Our referral center is incredibly overworked, and I think oftentimes they're struggling to get through their own work, let alone coming to teach us, coming to do the outreach that we need. So we've kind of reversed it, and we end up doing a fair amount of in-reach that side. And what it's done is it's given us a growth of skills, but it's also given us the relationships, and it's helped us build the trust of the referral center that actually, there are a few hospitals, district hospitals in our area that are able to do more than certain other district hospitals. We are better staffed than many other district hospitals in OR Tambo, so we should be able to do more. And I think just having that relationship develop has made a world of difference.
Thank you everyone for your comments. I'll hand it back to the presenter, see if we have any last comments.
Well, thanks everyone for your inputs. It sounds like, if I can summarize what I've heard from you, that we need sort of individualized learning nodes. So certain contexts need specific or have specific learning needs, but those learning nodes need to be driven by appropriate leadership. And it talks to, I think maybe it might become a buzzword for the conference, I've forgotten the buzzword already. Organizational culture, that's the one. Leading from the top down, promoting learning, and that's all fine within a facility, but we also need to sort of programmatize the prioritization of learning in a rural environment, so that people can be released for in-reach, so that it's seen as a valuable exercise, so those relationships are made. So thanks for everyone's inputs.
I think just as a take-home thing for everyone, go back to your environments. Find out what works for you, what doesn't work for you, what are your needs, what can you better be equipped with. And I think the next presentations are actually just going to further unpack this topic for us. Thank you, guys. So next up, we have Jenny Nash and Madeleine Möller. So Jenny worked in Umseleni Hospital for 10 years. I actually know Jenny as a young girl growing up in Umseleni. I was very young.
She now works as a family physician in Amatole district as part of the DCST in the Eastern Cape, and has 150 clinics, 5 CHCs, 12 district hospitals, a TB hospital, and a mental health hospital. She's very interested in supporting PHC nurses and doctors and clinical associates. Welcome, Jenny Nash. And then Madeleine did family medicine through RCAP in 2004 in the UK. From 2006, worked in HIV TB in Eastern Cape and was involved in decentralized training and mentoring in HIV in rural district hospitals. At the moment, she's working in Mqubela TB Hospital and outreach for drug-resistant TB for Butterworth Gateway Hospital. Thank you so much, guys.
That was our 3-minute handwritten bio CVs. Thank you very much. We've had an amazing start to this session because it's exactly set where we want to go this afternoon. And this afternoon is going to be a conversation. It's going to be a very active workshop. Don't worry, it's not going to be fluffy, because one always thinks of mentorship as potentially quite a fluffy subject. But it's actually a conversation that's been happening and growing, I think, almost from conference to conference. And certainly at the last conference, there was lots of conversations happening, both in what was coming out of the plenaries and over the dinner table and on the aeroplane on the way back, and then within Rudasa on the email forums, and we've had a telephone conference earlier this year. And you are now becoming part of that conversation, and that conversation is going to continue beyond today. And there's a mentoring Indaba, a Rudasa Indaba session. I think is that on Saturday, where a lot of what's going to come out of this is, so that what we're doing here is we're actually going to be creating ideas and innovations that we're going to take into practice beyond this workshop. So I think what will happen is you will get to know a little bit where me and Jenny are working together. We both are bringing different aspects of the same vision, and you can see we've called it Thriving in Rural Healthcare, and we were having this teleconference earlier this year with a group of amazing people, and there's always this concept of how do we help our young doctors survive rural healthcare? You know, it's like sending them out to the war zones. And I think it was Bernard that was saying, well, hold on, it shouldn't be about surviving, it should be about thriving. If you're going to go out and live in rural health facilities, we want to be professionals that thrive in what we are doing, not simply surviving. And how do we do that? And we're going to look at one aspect of that. So I want to start with this very simple question. Rudasa, and I'm particularly saying Rudasa because I'm looking back to when we first started. Rudasa was the first organization that got set up within this rural network, and it's been beautiful how it's now grown into a rural health conference. But the thing that brought Rudasa together in the first place, and always comes up when we have strategic meetings or when we talk about why Rudasa happened in the first place, is it's about connection. That's what it's always been about. It's about rural doctors connecting with each other. And this has now become much bigger than just doctors, and is now including our rehab colleagues, our clinical associates, rural health nurses. And connecting is, yes, rural doctors to other rural doctors, clinical teams to rehab teams. We've talked a lot about creating communities of health. So your doctor, your clinical associate, your nurse, your rehab team, all of these different rural health professionals trying to provide services in rural areas. But it also includes linking us to mentors and experts. And sometimes that's even just linking you to a doctor that's 2 years older than yourself and has done a little bit more. Mentoring is not just to fancy experts and fancy hospitals, but it's also knowing who's the local person who knows about diabetes or knows about HIV. Oh, Jenny is my DCST, I can call her for this. My role is in drug-resistant TB at the moment, so in the Eastern Cape, on the eastern provinces. If you've got a question about DRTB, then you WhatsApp Madeleine. So we create networks of who do you ask when you're stuck. And Rudasa is now being able to link nationally, so we are able to link to specialists, colleagues, mentors through the forum in South Africa. And we're also linking internationally through Wonka and what's happening in rural communities across the world. So this little connection drive that formed Rudasa is still what drives us from year to year. And I'm going to ask a very simple question, which, why do we need to do this? Why is it so important to connect? And it's very simple. To be able to thrive, we all need connection. And I think this all makes common sense for those of us in rural health facilities, but there's also more and more evidence showing how human connection is what is needed for us as human beings to flourish and to thrive. And there's wonderful work done in psychology. You can still hear me? Yeah, that's perfect. So in the world of psychology, there's a big field now of what they call positive psychology. Rather than all about how do we deal with our fears and anxieties, how do we actually thrive and flourish as human beings. And human connection is one of the most important things to help us thrive as human beings. I remember when I was a young doctor at Frere Hospital, I did my internship at Frere, and you have that strange experience as a young doctor of suddenly not sure why you're doing what you're doing. And the challenge I was having is that when I looked at the doctors that, sort of the older medical officers or registrars or consultants, there was nothing really that inspired me as a young doctor in terms of how we worked with patients. I had an experience of a baby coming in that was acidotic, I think probably from gastro, and died as we were trying to resuscitate. And it was me as an intern, and there was a medical officer. And there was a young mother, she was maybe 19, 20 years old, and she was in the room, as it goes, all this chaos of trying to save this baby, and the baby passed away, and this mother wailed. And I had no idea what to do. And nobody in that room had any idea what to do. And feeling, he was giving this example, the speaker this morning, of when people die, how we just, close the curtains and cart off the body, and this inadequacy of how we deal with it. And we have it because we don't really see examples in our academic institutions of what do you do in those heart-wrenching situations that one's in. So a few years later, I was in the UK at that stage. I was finally in like a hospice setting where we were doing holistic health care. And I had finally met doctors that I would look at and think, one day when I grow up, I want to be like that. And this one doctor, one of the things he taught me, just his manner was extraordinary with patients. And he said to me, he was Dutch, but every single patient that comes in, you would walk to the door and you would greet them with a handshake. Every single patient. You make eye contact and you greet them with a handshake. So I was taught this and dutifully learned this from this extraordinary man. And I've done this my whole life. So now I'm working at Nkqubela TB Hospital. We have 4 doctors' rooms in OPD, and we have a long passage where the patient sits on little chairs. And with every patient, I walk to the door, Ulandelayo, I call in the next patient, and I greet them in whatever language they speak at the door as they come in, and I make eye contact. And I do this, so therefore I get up and do this, 20, 30 times a day as patients walk into my room. And the one thing I've learned when I've read the woman I'm referring to with this connection need is a woman called Barbara Fredrickson. She speaks about these moments of human connection. And what I've learned is that, of course, it's lovely for the patients. You always have this moment. They always laugh at me or slightly surprised, or there's always a lovely moment that happens in that moment. But I've realized the person that benefits the most from it from a daily basis is myself. Those moments of human connection is what makes my busy OPD day possible. And it's human connection that makes us feel that what we do matters and that what we do gives us. So in a rural health setting, we need connection because it helps our doctors to thrive and survive. It makes better clinicians because if we connect with them and they can connect with their patients, they care. It improves resilience and it reduces burnout. That's been shown. If you have support networks around you, it's very different than when you're in isolation. It improves retention. So we spoke earlier, somebody was saying if you've got clinical managers who care and want you to learn, those are the facilities where you stay. If you're somewhere where you're in isolation and you never learn something and nobody encourages you, that's where you might decide to move off. And it transforms people's understanding of health services if they're able to be in a rural health setting and they start to see how human connection can make a difference. So we've been looking very much, myself and Jenny, we started off with a conversation on the aeroplane on the way back, looking at how do we really up our game in the Eastern Cape with mentorship and with creating this rural network of connection. So how do we do that practically? It's already happening in little pockets. We have all kinds of things we find when we look at the forum, and little facilities that do amazing things. But how do we take it to a next level? And how do we practically do it with the resources that we have? So out of that, there's arisen a vision. And I like Peter Senge, who's written The Fifth Discipline. It's a brilliant book about systems theory. And this is not a vision statement. This is a shared vision that's been arising from talking to people. And I've already heard it this morning through the plenary discussions, already through what Adam was hearing. There's a vision that's arising from rural health clinicians on the ground of what it is that we need. And we've tried to describe it a little bit about what that would look like. And what we are wanting to really create is a rich, sustainable, living network of rural health practitioners, clinicians, we can call them buddies, mentors, experts, champions, but all of us working within rural health. How do we create a rural health network? And I'm going to use the Eastern Cape as an example because that's where we are, that's really living and active, that every little district hospital within the Eastern Cape is aware of that network and feels themselves a part of that network. How do we create easy access for those clinicians within that network? So who do I call, or who do I WhatsApp, or which WhatsApp group do I belong to when I've got the patient in front of me and I don't know what to do? Who do I contact when I myself am feeling like I'm not coping or something has happened? Every now and then, and Jenny's also had call of that, you'll have doctor who's had a needle prick injury themselves and need to speak to somebody. You know, who is the person that you call when you yourself are affected in some way? But also the next step, which is this lovely conversation this morning, is also how do we create proactive opportunities for junior doctors or young doctors or new rural doctors or even old rural doctors for support. So is that outreach, through InReach, through workshops, what's online, what's available, what kind of opportunities can that be that's appropriate to the learning needs of your different doctors? And how do we create to be able to sort of, all of this needs to be in some ways facilitated, and so we are looking from a very practical point of view at a comprehensive portal. So there's already something on the Rudasa website, which is sort of like a link of resources, but we want to start making that really active. So if you're a doctor and you have a learning need in a specific area, that you can go somewhere to find out what information is available for me and to have it appropriate for rural health care. And who do I call when I'm stuck? So if it's drug-resistant TB, and I'm now suddenly having to run the drug-resistant TB decentralized site, that I'll be able to go and find the newest guidelines on it, maybe some training YouTube videos that gives me a little bit of an idea of what's going on, and maybe the number of Dr. Muller, who's the mentor on MDR TB, to ask questions if I'm stuck. So how do we start creating something that the doctor, if they are identifying their own learning needs, know where to go? So Peter Senge speaks, his whole book, The Fifth Discipline, is about how do we create organizational learning. So he uses that as a picture of a organizational culture that's different from the control hierarchy cultures that we are so used to. So we're not going to change the DOH overnight. But we can create a structure. This network can have its own rules. It's not going to be a control hierarchy structure. It's going to be a structure that's created by clinicians, and it's working on a different premise, which is that we are always learning and we are always developing. And how do we create opportunities for us in rural healthcare for that learning process to always continue? So Senge gives this lovely picture of what you need to start with. Is we start with this vision of what we want to create in the Eastern Cape. And then we have to look at where are we now. And in the world of personal, he calls it personal mastery for organizations and human beings, being able to understand this, where we want to go, and then to be really honest about where we are now. And that's a bit of a challenge sometimes within the DOH, because we don't want to look bad. So we're not always that good at reflecting as organizations about what's actually happening at the moment. And I mean, we can have a few ideas. I mean, where are we now in terms of rural healthcare and networking? I can talk for the Eastern Cape. But in your areas, let's just have a little bit of interaction before it gets too dry. How's rural health set up at the moment for interacting with each other as facilities, as clinicians?
Hello.
So that's a lovely, yeah.
The WhatsApp group was started originally so that when road protests were breaking out all over the place, so you could sort of find out if you had a chance of getting to your destination when you set out for the day.
It's beautiful. That's a beautiful
but
example
it's been used
of
for
how
other things and chit-chat and whatnot.
how things have moved on.
Yeah.
So that's a good example. So in the old days, when you were in a hospital here, you would have no idea what's happening in the hospital next door. But suddenly technology is starting to blur those boundaries a little bit. So there are amazing WhatsApp groups both for local districts. There's also amazing national WhatsApp groups. One of the great groups that's running at the moment is the IDSSA group, the Infectious Disease Specialist group. There's an adult one and a specialist and a children's one. They've got 5 or 6 ID specialists from across the country sitting on that group. And if you post a question, you get a reply within 5 minutes, which is great when you're in a rural health setting to get answers. So we're starting to see there's more things out there, but a lot of people don't know about some of the groups that are available. Other experiences in your rural health settings? At the moment, we're still looking at brutally honest about things that's also difficult or challenging in terms of networking.
In terms of rural to rural communication, I think a few years ago within Rudasa we sort of branched off and set up provincial groups. They kind of worked for a little while but then fizzled out. So I do believe those groups still exist somewhere in the online ether.
One of them is online computer, I think, yes.
Yeah. I don't think they really took off to the extent or were used to the extent that we felt that they would. So that was an idea. And I think like with the way things are moving, WhatsApp does represent a much more responsive form of social media than email. I think a lot of people are still used to sort of saying, when I get home, I'll check my emails, whereas WhatsApp you kind of deal with on the fly.
So that's a nice example of things of that where there's this need to try and create something, but it doesn't always work. I'm just going to... So these are some of the things we have found in our area when we were looking at what is the rural network looking like at the moment in the Eastern Cape. And what we tend to find might be not so different from your own areas. So most of our facilities are very far from each other. So there might be some WhatsApp groups, but I think a lot of our facilities are still very isolated, even within the districts. And our districts are huge. In Amatola district, Madwaleni Hospital and Pedi is about 4, 5, 6 hours drive from each other, district hospitals. You've never even heard of Pedi. It's on the other side. So you have district hospitals in the same district that are almost in completely different cultures. They're so far from each other. The hospitals are very understaffed. So Adam gave that lovely picture of if you don't have that many doctors, it's not that easy to start creating networks because you're just keeping head down and trying to survive. The biggest challenge, and that's why the groups struggle, is the high turnover. So what we find is you start creating, oh, this person is here and that person is there, and you maybe have a meet and greet of some kind. And then 1 year later, half the people have left, and then that sort of fizzles out again. Our management structures in our hospitals are very hierarchy-controlled, top-down structures. And they don't, I think, even make apology for that. That's the way we do business in all bureaucratic institutions in South Africa. And those make it not so easy to network horizontally. Matter of fact, you're probably not allowed to talk to anybody else unless you've got permission from your manager. Even just putting Facebook pages together can be a challenge. So there's a bit of a challenge in terms of these very top-down structures trying to create lateral structures. Clinicians generally feel very isolated. So we have some amazing projects within Eastern Cape of hospitals where they've got great support, and they, I know Zitulele and Madwaleni's got this run that happens between the hospital once a year, so then they run miles just to see what the person looks like on that side. But that's the exception, it's not the rule. Most of the young doctors, when they arrive at Kanzebe Hospital or some of these smaller hospitals, find themselves very isolated clinically. It's huge diversity, which is great, but also challenging in terms of you will have doctors from different countries, different languages, different backgrounds, different ages, and they change very quickly. So that makes it very difficult to create a uniform group of people that get to know each other and build relationships over time. It's definitely skewed to junior staff. So I think most of the Eastern Cape is run by doctors under 30. That's skeptical, 35. And then there's some great senior doctors that stay and give some support, but a lot of them end up leaving, going to specialize or going into private practice or going to urban areas. Poor resources and infrastructure, accommodation, not having the right equipment, and no Wi-Fi. Probably our greatest challenge when we start talking about communication and portals and fancy training programs and webinars and all of these things. So this is where we are at the moment. This is not to make us depressed. The idea, according to Peter Senge, is that if we're able to create a real vision of where we want to go, and we can look at really see where we are, it creates creative tension. That creates energy. And that's what we're hoping to do today. We know where we are, but we have a vision of where we want to go. And I believe in this room, there are already remarkable experiences. You've all had experiences of having extraordinary things happening around mentoring and network in the past, things happening at the moment, and you might have dreams and ideas for the future. And we want to start looking at which of those ideas can we actually start making a practical reality in the next 3 years. Okay, so let's put a time frame on it. According to Peter Senge, 5 years is too long, 1 year is too short. So we're going to work on a 3-year vision today. And what we particularly want to do, and we're going to work out, we'll do a few exercises. The workshop's going to rotate around this. We'll give you the exact exercises later. But the goal is that we wanted to develop a clearer and detailed vision of what we mean by this living rural network. So how do we link and communicate rural clinicians? So already starting to have a discussion that email is probably not the best way to do it. So what other innovations are out there? Having a discussion around apps like Vula versus WhatsApp. What are advantages, pros, cons? What other things may be out there that we are not aware of? What can such a support network look like? And we're looking for something that's completely inclusive. How do we do that every little district hospital is part of that network? And how does a young doctor who arrive at Lusikisiki at St. Elizabeth Hospital, how does he or she know where that network is and how does he or she link into that? So in January, when all the ComServes arrive, what do we create to make that possible? And then the proactive networking, which is where Jenny is going to tell us a little bit about what she's up to in terms of in-reach and outreach and innovations of what we can do as mentors and specialists as well. So we want ideas. Secondly, I'm very interested in this online rural health resource. There's a lot of talk at this particular conference around this word curriculum. I don't actually want to use the word curriculum. I'll mention in a minute what I mean by EPAs. Those of you in the academic circles might have heard of it. But we do want to get to the point where, as a doctor, there's actually a structure of what is it that you need to know to function as a rural doctor. So when you walk in and you're a young ComServe, okay, what is all the stuff that I need to know to be able to manage, and where do I find that information? So if you're quite a proactive doctor and you want to do a bit of reading and you want to have that first month to orientate yourself, where do you find that information? And Jenny's also going to talk about how we prioritize. What are the key things that you need to know, like resuscitating a baby who comes into A&E. And then we like the idea that if you then have this portal, that it's linked to resources. So if I am wondering about how to resus, then I get linked to the most appropriate resources for my rural environment, as well as who is my mentor or expert that I can call on when I'm stuck, or which WhatsApp group I can use. And then this is my particular passion, is that mentoring is already happening within our areas. Jenny and I mentor all the time in our particular fields, and we are being mentored all the time in our particular field. So I've got an infectious disease consultant, real privilege at my local hospital that I can call when I'm stuck. And then there are doctors in decentralized sites that can call me when they're stuck. And mentoring is something that one has as a passion, but there's definitely a toolkit of how to become better mentors. So it's partly how do we capacitate our mentors, and how do we also help to identify and train up more mentors within this network to be available for these doctors. So we're going to be having conversations in a minute. And to start the conversation, because as I said, it's been an ongoing conversation, I'm just going to bring a few concepts that's already been going around in our discussions. And I'm very glad for some of the things you have already brought this morning, because that's all part of the same conversation, these learning needs of our doctors. So the one question that Jenny and I both had is around these resources. So we have this idea of having all this stuff you can go and find online, and then you have to structure it. And then the question was, how do you structure it? So how do you literally form your structure? And then I was sent, I'm currently an examiner for the Colleges of Medicine for the Diploma of HIV Management. And the Colleges of Medicine are busy changing the way they do business to be more in line with what's happening internationally, and to make sure our examinations are more reliable and our curriculums are more up to date with what's happening in the world. And so we were sent on a training to look at, as family physicians, we're going to take on this particular examination from the infectious disease guys. And so we were looking at how to make this more appropriate, and so that we had a conversation around curriculum development. Now, I'm not fixed on having one particular way of doing it. I understand it's an area with lots of research and ideas. But I liked this concept that underlies what we are busy doing for the HIV diploma. And I've put it on the screen there. And the question we ask when we create our guide or curriculum or whatever we're going to call it is, what do we want to trust the rural doctor to be able to do? So for the HIV diploma, we're asking the question, if somebody has the HIV diploma, what can we trust that they are able to do? And so I've translated this question a little bit for our rural setting. And I like that word because it encompasses everything: knowledge, skills, soft skills, hard skills, everything we need to know. And what a rural doctor, if they're in their little A&E there, what should they be able to manage in terms of what comes through the door? And so it is a whole field around, it's the next step now after outcomes-based education. And so they have to have a fancy abbreviation. The fancy abbreviation is something called Entrustable Professional Activities. Entrustable is not even recognized as a spelling word. It's got a red line under it. It's a new word. And it's called EPAs. And the only difference is that at the moment, if you go to your EML and you go to renal conditions, you'll have a list. Glomerulonephritis, AKI, chronic kidney disease, you'll have all your kidney conditions. If you structure your curriculum according to EPAs, you might have, how do you manage the patient with a high creatinine? And then under that, you can have smaller section of what they call observable professional activities, which are all to do with the kinds of clinical scenarios you might see. So how do I manage a patient who comes in acutely ill with a high creatinine? How do I manage a diabetic who's chronically ill with a high creatinine? And so what happens is you start off, it's the good old-fashioned, what they used to call in the old days, problem-solving medicine. You start off with what you see in the consulting room rather than starting off with a list of diseases. So does the young doctor know how to approach jaundice in a patient who's on TB treatment? Does the doctor know how to approach a woman that is pregnant that comes in and is bleeding? And out of that, you then create your own structures. So for the HIV curriculum, we have found it interesting. We've taken out immunology as a topic. We've taken out virology as a topic. The information that is relevant will still be there in the exam, but it's part of understanding HIV resistance. So how do I manage the patient who presents with virological failure? And part of that means you have to understand about genetic barriers, et cetera, et cetera. So it creates just a different way in how we approach the way the website is set. I'm not set on this as a method. I'm trying to stimulate conversation. So one of the things we're going to look at, and I'm looking for ideas on, is how we're going to structure this information on the... Now, I've already created... we've taken this and experimented with it and creating... And I've brought some printouts that you'll have when we have a discussion. And what I did is I took the EML topics and we've tried to translate them into these areas. And what becomes also interesting is when you do that, especially if you're working in district hospitals, you'll start noticing the gaps. Oh, this is not covered, and that is not covered. And if you wanted to figure out how to manage patients who come in with high creatinines, where do you go and find that information? Because unless you already have an idea of the diagnosis, the EML is not going to give you any answers. And then if you go and Google it, you can get some very interesting down the rabbit hole. So this is just to stimulate ideas of how do we structure the information that we are going to put online. So we would love to have some help from the SAJ, the Family Practice Journal, on this kind of a thing. Start looking at structuring information. And so we are looking at a rural health resource structure. Jenny will talk more about also then, this is now a massive information, but when the doctor comes in, how can they also find like the key things they need to know before they start? You'll talk more about that. Almost there, okay. So I want to just bring a last couple of concepts. I don't know if any of you know Roger Neighbour. Might be before your time, you're not all too young. He used to be the president of the Royal College of General Practitioners. He was there when I was doing my specialization 15 odd years ago. And he was very interested at the time on the training of GPs. So in England, when you do your training, what they call general practitioner, it's actually very different than family medicine. But you do a year in general practice and you have a GP trainer and you're like a GP apprentice and you get overseen by this GP trainer. So he was asking the question, what makes an outstanding doctor? So he wrote to all these GP trainers and he asked them to tell them about the outstanding doctors that they have seen when they've completed their trainings and to write about the qualities. And then he's written a beautiful book called The Inner Apprentice. Those of you interested in training and mentoring, it's very much worth a read. And then he put together the qualities. And what he also says, when you go through these, we're going to go quickly through them, how many of these are being taught within medical school or rural health settings? So these are the qualities of outstanding doctors. Response to novelty. Caritas, so that's this empathic, understanding, caring, approachable. Clinical competence is in there. Group ability, so being able to work in teams. Personal qualities such as sense of humor, affability, maturity, you know, the kind of people that's nice to work with. Educatability. Oh, I didn't spell that right. I'm not that. Motivation, balance, industry, communication skills, only 16%, but still. Mission, critical ability, that we might teach, hopefully, in medical schools, and diversity. And if you look at that list, these are all the things, if we think about our outstanding doctors, these are the qualities we have in those doctors that do extraordinary things, but how much of that is really part of our curriculum in medical schools or within our rural health facilities? And then the next question is, but how do you teach that? Maybe they're just born like that, or depends on the school they come from, or, you know, what kind of example have they had? How do we take these young, impressionable people, and is this just they come like this and you're lucky and they care and you have a great doctor, or maybe they don't have that many of that qualities and they're somebody that we struggle with? And Jenny and I both, of course, have this great hope that all of us have the seeds of these kinds of, the thriving doctor have a lot of these qualities inherent. But actually, one of the most powerful ways of helping a doctor find their path to some of those qualities is through mentoring. And that is a Socratic path. So Socrates, extraordinary man, who particularly worked through teaching through the one-to-one interaction and asking the right question at the right time. It had to do with human connection. He knew the people that he was busy teaching, and he didn't teach them through coming with all his own ideas. And he also didn't teach them by asking them to tell them everything they knew. He did it through dialogue, through being able to see what they brought, and then being able to bring the right question at the right time, and being able to respond to what he saw in the right way to help people come to places they never thought they would have through their understanding of the world. And that's what a great mentor does. And great mentors have got a natural ability to be able to somehow find out for this particular person, what do they need to be able to go forward in their learning path. One of the most challenging situations that, I can put that one on, one finds when you're a mentor is when you're in a scenario where you're on a ward round, for example, or you're going through an file audit, and you find scenarios where things have very obviously gone very, very wrong, and quite often to very clear detriment of the patient. Mortality meetings can be quite scary. When you go through folders and you go, no, yeah, we actually really messed up in this scenario. And I was saying to Jenny earlier, when I was going through this, I realized with doctors, I think because mainly I've also obviously been there, and we've all made mistakes, and we've all had hard days, and we've all had things you do, and you later go, oh, why on earth did I do that? You find you're much more able to look at, okay, great, how do we learn from this? How do we shift this on? And, I find myself, I struggle to be as sympathetic with the nurses. When you get the next morning, I was just saying I had a patient earlier this week, and I came into the ward, and my patient was massively dehydrated. And yet mentoring, to really move it on, takes a different skill set. And how do I change my organizational culture within my ward to create a different way in how we look after patients? And me shouting at the nurse, which at that moment is very tempting, is not going to do that. And that takes tools. It takes a skill set to know, well, what do I do? Because the other thing is you just keep your mouth shut. Fluid chart, please make sure you chart. And so for me, this mentoring is a key role in this rural health network, but it needs skilled and caring mentors. And it's an art, but it can be developed through training and practice. And I am very interested in developing a mentoring program. So we've got all this mentoring happening all the time, whether it's clinical managers or DCSTs or senior doctors mentoring younger doctors, experts, ward round. There's all kinds of mentoring moments happening all the time. And yet most of us has never been given a tool or skill set on actually how to best manage a scenario like that. What do you do when you're standing in that ward round and you pick up things that needs to be improving? And for this, we need training and workshops. Some of them interactive, some of them can be online. This is also work that still needs to be developed. And there are extraordinary fields of science out there in working with this. Any of you ever watching TED Talks? Lots of stuff on TED Talks. I'm sure those of you have heard about appreciative inquiry. Some wonderful work around appreciative inquiry in terms of how you approach difficult conversations. There's some great stuff that's come out lately on the art of feedback and revolutionizing the way we give feedback, especially in the corporate world. It's becoming very fashionable. Systems theory, being able to understand that we create systems that creates the fact that my patient is dehydrated. So don't focus on the nurse, maybe start seeing the patterns and the systems in the wards. Personal mastery, how do we ourselves work in terms of when we make mistakes, and how do we help people feel safe to be able to learn? So these are just lots of little concepts that can go into a training for mentors. I'm now going to ask Jenny to talk a little bit about her experiences of BAMC, which is some of the ideas we're also adding to the conversation, and then we're going to move on to the workshop side.
Good afternoon, everyone. So BAMC sounds a bit like a little baby doe, like a buck. So we had to come up with a name. So just as background, we wanted to provide some form of support to the doctors in our district. So over the last maybe 2 or 3 years, we've been encouraging the specialists to do outreach to different district hospitals and to do teaching ward rounds, to make contact with the doctors. And we've tried various tools to try and get feedback, etc. So we put a document together for Discovery Health to get funding. And we were granted some very nice money to do that. So we had to come up with a name for this program. And we kind of brainstormed about various things. So we eventually came up with the Buffalo City Amatola Medical Support Initiative. So that's how BAMC came about. So it's not a buck, and it's not some kind of foreign animal. So BAMC was developed probably towards the end of last year when we got the funding. And there's been a lot of red tape and a lot of paperwork around moving money between different organizations. And so we've seen some of the frustration about that. But maybe just a few things that we were thinking of is that we wanted to have it as concept these 3 things to support our doctors. We thought it was important that rural doctors were able to come and do in-reach in the department. We wanted to do outreach, mainly on a relational level, to build contact so that when a person phoned, they had an idea, both the consultant had an idea of the environment, and also the district hospital knew who they were contacting. And then we wanted to develop some online resources. So Dave Stead and Prof. Parrish, many of you know, and myself, along with some IGH fellows, and we've managed to bring one along called Jan Wong has come with us at very short notice. And we've started working on this. And really, the idea that we wanted to do is create a sort of a network that is sustainable. So it doesn't depend on just one person. It has a system. So obviously the money helps. It's a 3-year grant where there's accommodation. We've got money to provide accommodation for the doctor in East London. And there's also money for the person to travel to East London. So if they're at a rural hospital, they'll be able to put a log in and log, and we will reimburse them for the money that they travel to East London. They're able to stay in accommodation that we've organised for a week at a time. They will have to pay for their own food. It's self-catering. But then they will be able to attend all the academic meetings in that facility. And part of that idea of thinking, what does in-reach look like? We don't want people just to arrive and then sort of tag along, which is often what happens, especially for a short term. And so we've developed a logbook where someone arrives, they have a meeting with the consultant, and it's quite clearly mapped what are their learning needs, what do they want to get out. And we're trying to identify 1 or 2 specific clinical skills and 1 or 2 maybe more medical things that they want to learn about. So a clinical skill might be improving reading a chest x-ray, it might be learning how to do a Doppler, another sort of more clinical skill might be looking a little bit more about managing the jaundice patient, something that they feel that they've got a gap in. And so this logbook has got a number of pages where the person coming into the facility is able to mark that with the consultant and then plot a plan during that week. Now, a week is a very short time. So there are a number of set ward rounds that they will join and academic meetings. But what we've done over the last maybe 2 or 3 years is developed what we call an audit toolbox. And so this audit toolbox has things that we feel will benefit a district hospital that cross-cuts different disciplines. So it's focused on, for example, prescribing, rational prescribing, IV fluids, things that doesn't matter if you're in a pediatric department or if you're working in a male medical ward. And there are about 5 of these ones that we've identified. And what we're encouraging is the doctor who comes to the in-reach facility to do an audit. So they'll choose an audit that they would like to do. And we keep on stressing it's kind of a 5-chart kind of review. It's not a huge, massive audit. They will then present their finding on the Friday meeting before they leave. They also do one on call up until 10 o'clock at night, just to see that grass is not always green on the other side. And then the idea is that they will be able to take that audit tool that they did back to their hospital if they don't want to do that particular one. So a big part of the link between in-reach and outreach is to be able to support leadership in your district hospital. So we realize often that what lacks is that there might be young, enthusiastic junior doctors, but they don't know how to go about making change. And so by doing an audit or by having some buy-in is to be able to encourage the person who goes back to share what they learnt in their in-reach facility and not necessarily try and change everything, but say, I did this particular audit and, can we do it? So the idea then is that when the consultant comes out to visit, they will make contact with that doctor and be able to say to the clinical manager, did you follow up on this audit or which audit have you done? To try and close that gap about the people just disappearing into the kind of a black hole and to try and link. So what we've really learnt is that outreach is not so much about seeing patients, but it's a lot about building relationships. And I think much as what has already been said, when you do in-reach and outreach, it's more about getting to know people. And I think that's what we've sensed now with creating this network. If you know someone's name on the other side, it increases the chances that your referral will be slightly better, because you will know that I'm referring to Dr. Hendricks. It's not just a nameless, it's not just a faceless person. And I'm sort of feeling almost responsible that I'll make sure I write the blood pressure in and I'll sort of note some of the observations. And it sort of brings a different kind of accountability. So in our thinking around this whole support thing, we came across 3 ideas that we wanted to support. We noticed that we wanted to support clinical skills. So we wanted to make sure that clinical skills are improved. We wanted to improve accountability. And accountability was between doctors in a facility, accountability to the community. That idea, as Ben mentioned earlier, that when I'm seeing a patient, I want to treat that patient like my mother, my auntie. And so when I've done a lumbar puncture, I want to get that result back. I don't want to just wait for Monday to do the LP. And then that accountability to your referral center. And the only way we felt we could really improve that accountability was to improve relations and the relationship between people. And then we wanted to improve clinical reasoning. And that is a far more complex kind of layered process. But we are feeling that if we start tackling some of the skills and the relationships, we're going to start getting to the sort of clinical reasoning. And I think, as has been mentioned here, we now have medical students rotating through some of our departments. So we're wanting to try and create that learning environment. So people who perhaps are reluctant teachers, they will feel a little bit more empowered to give some teaching and training. And in terms of the resource development, we've also got a website which has been upgraded a little bit to try and see how can we make tools available. So we've got topics like reading the chest X-ray in a rush, the ECG on the run, dealing with a high creatinine, the jaundice patient, kind of things that we sort of need quick ideas, quick answers to. It's not the sort of medical school approach to jaundice. It's more kind of help. What do I do? What do I change? What drugs can I take away or add? And so this has been a process now. We've got about 80 topics where we've been trying to prioritize and say what is a priority. And so we've done a review of referral letters, looking at what do hospitals, my district hospitals, refer to the regional and central hospital, and what should not be going to them. So in a sense, what should we be making available? So we've looked at some of the things around, should we have sort of like PowerPoints with a sort of like a voiceover? Does it just need to be a one-page document, which is quick? Can it be a link to HIV Clinician Society guideline? Can it be a link to another site, such as ESMO-E or some of the established sort of websites that are already there? So these are some of the ideas that we're playing. We realize that these processes can marry. So we've got funding at the moment that we can develop this at the moment. It is 3 years, but we'd like to obviously to continue and to expand. But how can we make sure that these portals almost speak to each other? And I think that's what we're aware at the moment, is that many people have very good ideas and resources. So, for example, the Zitulele handbook. Now that's something that is well established and has been done. So it's no point every single hospital doing that. But could that be a link for other people, either to use those resources or to get an idea to do something just more summarized for their hospital? So one of the things that we really do need to think around is new doctors who arrive. And I think we've all got examples where a new doctor arrives and they don't know where they're staying and their name isn't sort of down anywhere, and they stumble between the HR, who's usually not there in the beginning of January, and they get told to find a nursing manager to get the key for some accommodation, and that just gets the feeling that you're not welcome. And so part of thriving in a space is also looking at the non-clinical issues. So what do we need to do as a rural network to support issues that don't necessarily speak specifically around clinical issues? Now, in terms of our in-reach outreach, we've realized that a lot of the miseries that junior doctors share with us are around accommodation, the geysers that has been broken for 6 months, and no one can get it fixed. The water issues, which sometimes even the hospital people can't sort out. So how do we point people in the right direction? And the more isolated a junior doctor feels, the less likely they are to reach out. And perhaps this is where we need to start thinking about trade union organizations and nursing organizations, where we can sort of become more part of bigger systems and get help from them. So, for example, Vodacom, they went and put some towers up in various hospitals to try and improve the network. And since Wi-Fi is one of our basic physiological needs, what else can we do to try and support rural doctors? How do we hear that and support that? And that may not be necessary on a clinical space, on a clinical website, but how do we point them to the right sort of place? Towards the end of last year, I'd been trying to think about how to welcome people into the district and trying to think, how do we make people feel welcome? And I have my own story arriving at Mussolini many years ago. And so at the end of the year, I got the list of our ComServes and post-ComServes who were coming into our district. So we don't have interns. And we had radiographers and occupational health people and the whole range. And I decided to send an SMS to all of those guys. And I sort of sat down and I started creating all these little groups and punching in millions of numbers and just sort of copying the same message to every kind of group. And I was absolutely amazed. So you can say it was maybe a totally kind of unthought through kind of activity. But I was absolutely amazed at the number of responses that came back. So this was sometime, we only heard, I think, the first week of December that we were getting these souls. And so the number of people who sent a message back to say, and it was a very simple message, to say, I see you coming to Amatola, welcome, we look forward to having you, please let me know if there's any problems. And I signed as Jenny Nash, family physician. And it was amazing how many responses came back of saying, wow, thanks, looking forward to being there, or I'm feeling slightly nervous, but thanks for the intro, or just little one kind of lines. Now, obviously, I didn't have people's names, I just had all these messages coming back. Sometimes people signed who they were. But what that's done is that now when I'm visiting some of the sites, I'll see a face and I pretty know everyone else, and I know that that's the ComServe, or that's the new radiographer, and going up and saying, hi, how are things going? I think you might have got a message from me. And that immediate kind of rapport. So it doesn't necessarily mean that we have to do very fancy things. What that did show me at the end of the year was between December and about the first week of January, the number of HR hassles that many of these ComServes and post-ComServes encountered. And between finding out that there were no posts and someone had been allocated from province, but there actually wasn't a post on the ground, and having to swap out people and create posts, we had a situation where a clinical manager would phone and say, please don't send me another physio. Like, I've got so many physios, I don't need another physio. And I knew that down the road, there was a hospital that had no physios. And then negotiating, swapping posts and moving posts around. And we actually had someone who was sent to a hospital, a radiographer, that had no X-ray department. So they literally were sent to sit. They sent me a photo of sitting in a room that was still being created, that had cement. And so perhaps that's the challenge is to for us to start thinking some of the things that we can do. If you've got a child, can you buy nappies, disposable nappies, if you use disposable nappies, close to you? Because sometimes those are things that make someone feel more comfortable about arriving in that environment. I remember years and years ago, that the clinical manager where I was working said, you can find everything, just down the road. But that family that were coming out had a very small child. They were coming from Ireland. And what they expected to be down the road and what it meant to get things down the road was very different. And that meant that literally outside the hospital, and as you know, at Mussolini, there's lots of vegetables. There's tomatoes and cabbage and potatoes. But these people did not think that was all their kind of needs would be found there. So perhaps that's the kind of discussion as well. It's not just looking at those kind of things. It's looking a little bit beyond HR needs, HR issues, and do we have a kind of a system, or do we just bury our head and we've all had to fight through it, and so we just know that you just soldier on with those HR issues, with sometimes the accommodation. Accommodation is a huge nightmare, and so do we have a way of supporting a doctor, or do you, when you've got your accommodation, you've classified as being one of the lucky ones to get a nice accommodation, you basically just deafen your ears to all the calls and the cries from the others? Or do you start engaging with civil society, other organizations that might be able to help? So as our district sites increase, we're going to find we're going to have interns starting to rotate through some of our sites. We're going to have far more medical students coming through. And so the pressure, both on the Wi-Fi connection, but also on accommodation, on your sort of basic resources, is going to get stretched. And so do we have a plan? Because part of that is what creates thriving. We don't want to just survive. We don't want people just to say, like, I did it, like this year. Do we have a way of supporting people who want to study further? So part of this is wanting to identify when you visit people and say, this person's really keen on the diploma of child health. How can we link that person so that they can meet the criteria and they can further their studies, because that's going to benefit our local hospital, and it's going to also encourage them to study in other things. So that's something. So, BAMSI, the little doe who I'm talking about, is a tool. We've got some funding. We're going to be using it as a bit of a pilot for the next 3 years. Specifically in medicine, we're going to be trying and get some anesthetics through, just because we think that acute care is very closely tied with medicine, so we might be able to do a bit of that. But the kind of challenge and for us to go further, how can we use both like this pilot to learn from others, but how can also this wider forum give us insights into some of the programs and things that we can do? There's a lot about having the capacity in a department. So yesterday I was in a meeting in the regional hospital where they're going to be doing InReach and saying, actually when you have 2 or 3 people coming into the department, that department needs to be on board. And they also need to have the capacity to do a little bit of teaching and to go through things. So it's got implications. You've got to have buy-in on both sides, like your sort of referral things. So that's the little story about BAMSI. And I think we just want to take some time now to discuss some sort of questions. And we would like it to be in little groups where you can really discuss and share your... So we just maybe turn around so that you can just, these guys turn and face those guys and those guys face. So you can just have little discussions where you are.
I'm just going to tell. Before you move, I just want to introduce one little concept. It's also from Peter Senge. It's called the word dialogue. So he talks about team learning, and obviously he just describes dialogue as one of these old Greek concepts. And he differentiates between dialogue and discussion. And what we're going to be doing this afternoon is dialogue, not discussion. And what that means is with a dialogue, we are going to build more and more ideas and innovations. And if somebody says something that you think will never work, then build on that idea until it might work. Discussion is when you start saying, this is what I think we can do, and this is how we're going to do it, and that's when you make decisions. And we quite often in our meetings at work, we spend a lot of time discussing and not a tough time dialoguing and building ideas. And we're at the point where we need as many ideas and innovations to come out of this group. So our goal today is to enlarge the shared vision we have of mentoring and a rural health network. And so I don't want you to get bogged down in talking about all the problems that there is. I want us to start looking at practical solutions. So one can say email is not working, but this WhatsApp group is working. This about Vula is really great. That we can perhaps add to it. We want to start generating ideas. And when we initially looked at it, we thought it was like I was saying, which is these castles we want to build? It's like these dream castles. And then Jenny was saying, no, we're building bungalows, not castles. It's fair enough. So we got 3 bungalows we want to build this afternoon. This is not a list exercise where you're going to all sit with one piece of paper and try and come up with lists of stuff. I would love you to have a discussion. If one of you's got an idea and you discuss that idea and it's an idea that you think, great, this is something we want to put on the list, then that person who's proposing the idea or somebody can get allocated can write it down for us on one of those pieces of paper and put your name and telephone number and email underneath it. So we actually want to gather a whole bunch of stuff at the end of today. And we also want a bit of time to hear about some of those ideas. But I don't want to walk away with a list that afterwards I think, I wonder what that meant, if you know what I mean. So we're looking at really practical ideas. And the 3 bungalows, so bungalow 1, innovations, ideas, visions of this rural health network. So good ideas of what works or even what doesn't work, but what could work or what needs to be improved from how we build a communication network between a whole bunch of district hospitals in a rural area. Bungalow 2, innovations, ideas, visions for this proactive support. So Jenny was talking about her ideas of how they do in-reach or outreach. You all might have ideas of things that's worked or not worked. I know Mareka is telling us they've got like a district event. I think it's every quarter with all of her rehab staff. So there's all kinds of interesting things that people are doing that builds proactive support activities. And then I'm very happy for any ideas on this rural health network portal we're talking about. Either how we structure it, things we need to add to it, ways we need to find through it. If you know of great resources or websites, even add that. So we're trying to generate information that we are actually going to build into this vision of what we're doing in the Eastern Cape. And we're also hoping, obviously, any of these ideas people want to start using in their own areas and want to try and pilot. And this is all about building shared ideas and shared vision by the end of this workshop. Okay, we're going to brace. Jenny says 15-15. You've got 15 minutes. Generate ideas. If you've got a good idea, you're responsible for writing it up for us.
You can come up with a good idea and you can get it to an implementation level, but having the energy and desire to keep it thriving is difficult. So in terms of establishing a rural health network portal, I don't see any big challenges with that, but keeping it going, keeping it current, I think would need someone in the role of an administrator to stimulate keeping it current. It doesn't need to be someone who does keep it current, but someone who stimulates the community to say what's new. It's the beginning of the year. We need new guidelines. We need new material. Has anyone seen anything cool? Otherwise, it'll be something that was established in 2019, and it will always remain a 2019 project.
So this particular discussion was really great because where we're thinking of doing is Rudasa really wants to take this on as a function, because there's nobody who really looks after the curriculum for rural health doctors once they post-ComServe. So if we as Rudasa take that on and that becomes part of our yearly function, our administrator is the person who has to do that. That helps with the sustainability. And then we were wondering, we've had some lovely input from UKZN about whether we can then allocate or use the universities to help us keep materials current. So we would have to look at how as Rudasa we ask to get help, but we don't have to pay some fancy expert to do it. We can perhaps look at people who are already curating material. If the family of you guys are curating some material, UKZN is already curating and got some videos they're using, so that we just start creating. Rudasa takes responsibility to keep that process going as part of one of our, because it's what we do anyway. And then we start using universities, and we have an offer from the medical students to potentially also help with ideas and inputs on that, the rural health clubs. So I really love that idea that we actually need to make sure who's going to be responsible over the next 3, 4, 5, 10 years for such a network to stay active even as people come and go.
Good afternoon, everyone. My name is Mukit. I'm one of the final year medical students from UCT. And one of the important sort of discussion points that we had was sort of helping health professionals or new graduates making an informed decision. And whether this is for interns or for ComServes who are wanting to come to a district level. And one of the resources that's sort of been launched recently, I'm sure the other medical students would be aware of that, is the site called ICSP. And what it has done is that it's sort of provided information about different facilities around the country. And why they're quite successful is that they've provided, for example, information about the area, what's down the road, what sort of activities you can do around in the area. And even more importantly is that they've included health professionals who've actually worked in the area and personal statements. So I think that if you could partner with ICSP, I can't remember, but but if you just Google them, you'll find them up. Yeah.
Community Service Program.
I think so. Yeah, that's one.
National Health is developing.
Yeah. So yeah, if you could partner with them, perhaps include yeah. So instead of reinventing the wheel, this is an excellent port. Yeah, maybe like include like a 30-second video of perhaps you speaking about why you're passionate about rural health and what, why coming to this area is a rewarding experience. So yeah, that's a way of providing supportive activities to young individuals.
Okay, our group thought WhatsApp groups were quite useful as far as what are we doing about here? Networks. And there's a number which, particularly for HIV and infectious diseases, there's SASPID and ISIS. Is that right? ICSS. Sorry, whatever it is. Okay. No, not ISIS. Okay. Okay. It's important these WhatsApp group have ground rules, or they have a lot of background noise. It was agreed that in-reach and outreach is useful for when it comes to referral harmony and communication between district and regional hospitals. Community service induction weekend was thought to be a very useful activity. There's a physio one at Zitalelli, is that correct? For the regional physio weekend.
So usually we take turns on a hospital who organizes the weekend, and then it's at one of the backpackers, or it's been at homestays before. So quite letting people know sort of where they're living and like getting them used to the Wild Coast. And there's a lot more about not just clinical skills, but who to contact, what's your lifelines, who's around, who's got what experiences around, and especially we found that a lot of our therapists has been placed alone in silos. So that's been very important for us as rehab. And it's proven, and it's not just the clinical stuff. We need, there's 1 or 2 clinical stuff that we address every year, but it's more about burnout and who you can contact and Take a Lot delivers and all of that kind of stuff. That's important for rural, yeah.
Is that in January every year?
End of January usually, yeah.
And who pays for that?
So it's either end of January, beginning February, so that people have received their first paycheck. It's not government sponsored at all, or everybody pays a fee. We organized food and accommodation, and that's it. Yeah.
Another thing which has been tried, not totally successfully, is cultural exchange between hospitals, and the idea being that each hospital has strong points, and if people just visit every 3 months, they might get ideas from each other. This has been planned and everyone's agreed to it, but come the day, people find they're too busy. But anyway, that's one possibility. There are also, when it comes to resources, a lot of places have drop boxes. There's hospital drop boxes, and there's district drop boxes, and I suppose you've got to mention the DOH internet. And the medical manager talks to everybody once a year. That's good too. He has a talks. Yeah, there's one hospital. The medical manager talks to everybody once a year. I think that was most of our. I think that was most of what we. Are we missing anything? I think that's most of what we said, isn't it? Okay, thank you.
The clarification about the once a year thing was that through the year he allocates an hour session where it's just one-on-one, you and him. So he does speak to us the rest of the year as well.
But the rest of the time he's still willing to interact with you.
In fact, he talks quite a lot.
Maybe I should mention Hans is not here, but Hans talked about the inter-hospital support, and then he mentioned Zitalelli, Madvaleni, but also Mseleni, Mosveld, etc. So, strong hospitals can support weaker hospitals, and weaker in terms of staff
I think one of the things that I was asking for is that when we meet like this, a lot of the times we tend to automatically think about clinical support specifically, which is great. We need to talk about that. But I think we need to talk about more about social support and mental health support. I mean, the idea of just telling someone, prospective staff or new people, about Take a Lot. For someone who is there and knows about it, it sounds like a small, tiny little thing, but it can mean a world to someone who's new or who's thinking about coming and is anxious, and so just kind of broadening that discussion to deliberately to go beyond the specific clinical issues to include mental health and social support and just kind of other kinds of support.
Yeah, I think it's great, the issue of clinical support. When I thought of mentoring, I had different view, but just maybe to add on is that one, if thinking supporting rural doctors is how do we, in my case, in most cases when I mentor and when I assist, is how do you manage to assist community in terms of their expectation? Do you understand community expectation, and then how do you respond to it? Because most of our doctors, they are to a certain extent highly clinical, and then we are emphasizing on it and say you need ECG and whatever. But now in rural, the expectation of the community is that we need a doctor who's fit for the purpose in the community. And then how do we make sure that the doctors that comes from rural area or work in rural area, they have that, and then that is the best outcome that in most cases we get. Yeah, and obviously the support of referral center, who to call and whatever must be there. But then what I'm missing is more of fit for purpose doctors, so that they can also feel that I'm special here, I'm different from other doctors, and I'm serving the purpose. So maybe we also need to look into that to say how you are going to make sure that that is communicated and is well established through the mentoring process.
So no, we're not looking into it. It's on now. That's it. It's on the timetable now. So the community engagement, also the presentation this morning, having somebody like this help us create material and ideas of community engagement. And I want to add nice online quick courses on learning isiXhosa for non-English or whatever language is in your area for people who are not speaking that language. So all kinds of skills that has to do with how do you engage with community, do you understand the culture of your community, what language skills can you quickly learn that will help you. So I'm going to add that as a section. Thank you.
And
Excellent.
when Madeline and I were talking, we actually also discussed and said we always have expectations of what we want from a clinician, but do we engage with the community and say what do they expect? What do they expect someone to be able to do? They may not necessarily sort of identify a resus skill. They may identify something else. So that is a good discussion.
Thank you, everyone, for staying so long. Thank you, Dr. Adam Asker. His supervisors left the room, Dr. Cyril Nkabinde, Dr. Jenny Nash, and Dr. Madeleine Merle. Thank you so much for such a wonderful session. I really enjoyed it. So I think just for everyone, think about how do we link and communicate as rural clinicians. What does support look like? As we were just thinking about the discussions that have happened during the group discussions now with Dr. Nkabinde, we're actually thinking, should we be thinking of homestays for ComServes? And I think this was based on the one weekend for the Eastern Cape guys. Some of our students that come out to Mseleni Hospital actually do homestays, and they stay with a family for 6 weeks. Can we do that for some of our doctors so that we better understand the context in which we work in, and we understand our patients and the challenges that they have and the determinants of health within the communities that we serve? That would be an interesting one. But how do we become proactive and actually intentional in these networks, and then thinking about training our mentors and supporters and actually making sure that they feel supported as well. Thank you so much, guys, for all that. we'll definitely take it home and think about it or digest it even further. The discussion doesn't stop here. And remember, we were told that it's not a discussion, but it's rather a dialogue. We build on it. Thank you so much, guys.